Hello, Kaplan Universe and MedHeads Worldwide. Again, it's your boy, Chris Paris, coming to you live again from my office. It's Thursday, so today's a light day. I have a half a day. But as you will see, once you become all grown up and become attendings, half days mean absolutely nothing because you have to catch up on nonsense bureaucratic paperwork. But doesn't mean I forget my obligations to you. So, like I told you, I would put up some answers and explanations about the two questions I put up, and a small little eensy-weensy mini talk on PCOS. Look, PCOS, guys, is a very complicated state. And the truth is, it was oversimplified for many years. And it's wrong. It's incorrect. And I can almost guarantee you, you're going to see PCOS on your exam and in real life, both. It's very prevalent, especially in the United States, exquisitely prevalent. It is the most common cause of oligomenorrhea in the United States, other than pregnancy. Right? Pregnancy is the most common cause overall. Never forget that. Always. Pregnancy is the most common cause of menstrual irregularity and amenorrhea. But the most common pathologic cause is PCOS, Polycystic Ovarian Syndrome. Up to 1/3 of women can have it in the United States, guys. Up to 1/3. It's a lot, depending on which state and region you're in. So, the underlying premise of PCOS is it's actually a pre-diabetic state. I'm not sure what you guys learned about it, but I'm telling you, it's a pre-diabetic state. The underlying mechanism of PCOS is insulin resistance. The same good old-fashioned insulin resistance that causes type 2 diabetes, same problem. And the problem is that the insulin-resistant state interferes with the aromatization of testosterone to estrogen in a woman's ovary. So for example, fellas, in us, the biochemical process, 95% of it stops at the test level. We're done. That's where our testosterone comes from. Ladies, for you, not the case. For you, your ovaries take almost all the testosterone that you make and you aromatize it into estrogen. And that's where your estrogen comes from. Now, and by the way, this is the same exact pathway that occurs in the zona reticularis of the adrenal. The same pathway, same one, right? So, when you have PCOS, the insulin resistance, the high insulin levels, interfere with the aromatization of test into estrogen. And that's why PCOS patients are virilized, right? Meaning they have acne, hair loss, right? They have these problems, thickening of the voice, they have these problems because of the high test levels. And I'll tell you another secret. PCOS patients also have a high DHEA level, dihydroepiandrostenedione, which is a testosterone precursor and an androgen in itself. All right. So if you see a high DHEA, don't get fooled. It's still PCOS. It's still PCOS. So you have your insulin resistance. You have your pre-diabetic state. So now what are you going to do about it? Again, guys, this is like a 3-hour lecture. When I give it to the fellows and the residents, it's a whole series. Let me give you guys a quick rundown, though. In essence, the way you treat PCOS, the way you address it, is you have to adjust 3 arms, 1, 2, 3, simultaneously. Arm number 1 is a woman's metabolic health. It's a pre-diabetic state, right? Therefore, you have to treat her metabolically, meaning weight, waist circumference, blood pressure, cholesterol, sugar. If you ask these women, it's almost unanimous, not all the time, but almost unanimous, that diabetes is in the family. If you ask them, it's almost unanimous. I would say about 80 to 90% of cases, right? Not all, but very high percentage. Now, about 70% are obese, but about 1/3 are not. About 1/3, a little under 1/3 are not obese. So that part of the paradigm is not always true. But diabetes is always around. It's always somewhere in the family, in the patients themselves, whatever the case may be. So metabolic health is the first priority because most of the time you're dealing with young women, right? 20s, 30s, 40s. These are young women, and you have to make sure that they're metabolically healthy. Sugar, blood pressure, cholesterol, weight, etc., etc., etc. Arm number 2, the second thing you must address in PCOS, a woman's uterus. A woman needs to bleed every month. She needs to shed her uterine lining every month because if she does not, then that lining can become hyperplastic. Remember that? You could develop uterine hyperplasia. That's not good because uterine hyperplasia is a pre-malignant state. We don't like that. We don't want that. So how do we prevent this? By making sure a woman menstruates every month. There are many ways we can do this, and I'll tell you guys that in a minute. The third arm is fertility. Now, it's a very common practice, I got to tell you, even amongst my colleagues, professional, other physicians, whether it's internists, endocrine, GYNs, whatever the case may be. Reproductive people, it's a very common error where they tell a couple, or tell a woman, oh no, sorry, you're infertile, you're going to have a hard time having a kid. It's not nice. It's not a nice thing to say to a woman or a couple. It could be very daunting. And first of all, it's not true. You guys see some of the fertility slides I put up. The definition of fertility is based on a year. It's not based per month. So a woman may have difficulty per month because she may not ovulate on a monthly basis with PCOS. That part's true. But on a yearly basis, women do ovulate with PCOS. It may not be every month, but they do. So it's not an infertile state. It's a subfertile state. And we can improve it. Most importantly, we can improve it. So it's not nice to, or I should say accurate, to put a woman or a couple through that kind of pressure, all right? So there are things you could do for it. Be honest, the truth is it's subfertile, but there's things you can do to improve ovulation significantly. So what do we do? Here's the moral of the story. If you treat the metabolic part, the blood pressure, the weight specifically, for most patients, guess what? All three improve. Because if you treat the metabolic part, you decrease resistance. If you decrease resistance, you improve your aromatization of test into estrogen. If you do this, you will ovulate. If you ovulate, you drop an egg, boom, you can have a baby. And you shed. If you don't get pregnant, you shed your lining, you menstruate, no hyperplasia. You see, you treat all three when you treat the metabolic part. For most women, not all, for most. Now, the best sensitizer overall is what? Lifestyle, diet, and exercise. By far, it's the best thing you could do. If that is not an option or it's just not working, another option, which is becoming the option of choice, really, is metformin. Because metformin is what? It's the sensitizer, right? It's the king of kings. It's the sensitizer. And metformin will cover all three bases. It will cover your metabolic health, if the woman, especially if she's overweight, and hyperglycemic, maybe pre-diabetic, if she has like an A1C of 5.7, 5.8, 5.9, 6, around there, right? And if by improving the resistance, again, she will ovulate and or not menstruate. So you'll cover all your bases. The only catch is metformin increases fertility. So if a woman or a couple does not want a surprise, you have to be careful with that. That's the only catch. You have to make sure a woman understands that. If the woman is healthy metabolically, let's say, I have a lot of patients where they hit the gym hard, they're good with what they eat, they're in great shape, their HDL is fantastic, it's above 50, their triglycerides are low, under 150, LDL is under 130 for a young woman, it's fantastic, blood pressure is good, but they're still not menstruating well. Then you only have to address the uterine side, right? Because metabolically she's doing fine. And we could do this with what? Oral contraceptives. That's what you use them for. Oral contraceptives will induce a menstrual cycle in a woman, which is what your concern is if she's doing metabolically well. Got it? Makes sense? So if metabolically she's doing well, you could use oral contraceptives to treat the uterine part. But understand, if you do this, she will not become pregnant. She cannot. All right? Now, if a woman is doing well metabolically, uterine-wise doing well, and then she comes to you and she says, you know what, I want to have a kid, right? What can you do? Well, metformin, I mentioned, increases fertility by about 30 to 40%. It increases what's called the fecundability rate. Fecundability is the odds of a woman becoming pregnant on a monthly cycle with unprotected intercourse. So it increases fecundability by about 30 to 40%. That's fecundability. There's only one drug that does it better than that, and that's clomiphene. Clomid, trade name called Clomid, right? Clomiphene. Clomiphene increases fecundability by 70 to 80%. This is why the incidence of twins and triplets is much higher when you use clomiphene, because you have multiple eggs, right? If you remember from pharma, we just have to, again, guys, we don't have time to go over everything, but it's a GnRH agonist. You could stimulate many follicles to mature and ovulate, etc. So clomiphene, though, will only address the fertility arm. That's it. It will not address the uterine part. It will not address the metabolic part, so be clear. So a lot of your treatment has to be tailored to what the woman's situation is. Is there family planning or is there not? Is she metabolically healthy or is she not? Is it just her uterus? Is it just her menstruation, which is altered, but metabolically she's doing well? You have to tailor it to what you need. Clear? That's a quick synopsis of PCOS. PCOS 101, kindergarten. Now, for the two questions that are up, question number one, I believe, situation of a young man who's hypogonadal, right? Or has low gonadotropes. The diagnosis there is Kallman's syndrome. If you remember what Kallman's is a lack of gonadotropic migration due to the KAL1 mutation. All right, KAL1 mutation. So gonadotropes don't go into the hypothalamus correctly. These guys do not make any GnRH, gonadotropin releasing hormone. If they do not make GnRH, then what will they not stimulate? LHFSH. If they don't stimulate, if you don't produce LHFSH, what will you not make? Test or spermatogenesis? Both. The way you treat this depends on what the man wants. If fertility is not an issue, if family planning is not a problem, then yes, you could give back testosterone. No problem. And you will virilize the man, give him the muscles, the voice, the male phenotype, the sex drive, all that stuff will improve. But it will not improve fertility. If anything, it will suppress whatever's there. However, if the man comes and says, you know what, I want to father a kid, changes the game. Now you have to stimulate spermatogenesis, right? Only two ways you can do that. One way is to give back the gonadotropes that are missing, the LH and FSH. LH by itself is wrong because LH only stimulates testosterone production, test production through Leydig cells, right? It does not stimulate spermatogenesis, so it's wrong. You need FSH, follicular stimulating hormone. The other option is to do a GnRH pump. Now, granted, not all centers do this, but some do, and it is growing. You could do pulsatile GnRH to stimulate spermatogenesis. And you know what? These men do very well. Whether you do the GnRH pump or LH-FSH combinations, they do very well. They cannot ask you which one's better. They're equivalent. For now, they're equivalent. But they do very well because LH will stimulate testosterone production, take care of the sex drive, and FSH will stimulate spermatogenesis. Boom, there you go. Or GnRH will stimulate both, right, through FSH and LH in the pituitary. Remember, these guys don't have a testicular issue. It's a strictly hormonal problem, all right? That's question one. Question two, young guy comes in, seems to be hypogonadal but doesn't add up, right? He has big muscles, he has acne everywhere, and his gonadotropes are suppressed. That doesn't add up, right? That's because why? He's taking exogenous steroids, guys. Exogenous anabolic steroids. He's juicing. On the street, they call it juicing, right? Unfortunately, many professional athletes do it. A lot of young guys do it. I see it a lot. We take exogenous anabolic steroids. Testosterone analogs, growth hormone analogs, because they want to get big. They want to look like Hercules. It unfortunately carries risk, right? Liver risk, testicular atrophy, probably some cancer risk. It has risk, but that is exogenous steroid use, right? It's exogenous steroid use. Things like mumps. One of the options is mumps. Mumps is famous for causing an orchitis. That's the opposite. That's a primary testicular failure, right? So you would see what? Elevated gonadotropes because of lack of feedback inhibition. If you have primary testicular failure, whether it's mumps or orchitis, whether it's Klinefelter syndrome, which is another option, right? 47XXY, remember that? That's primary failure. That means there's no testosterone production, period, from the testes. So now the pituitary doesn't see testosterone, so what's he going to do? He's going to yell to the testes, we need test. How does the pituitary yell? By releasing gonadotropes, right? So in primary failure, your LH and FSH will be high, right? In secondary failure, meaning a pituitary issue, your gonadotropes will be what? Low, right? Such as a pituitary adenoma. Chewing away at the pituitary, gobble, 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 right? Chewing away, beating up on the pituitary, you're not making any LH or FSH. Or a pituitary bleed, or pituitary apoplexy, post-radiation therapy, things like that. That's secondary hypogonadism. And the same patterns follow for women as well. Primary ovarian failure versus secondary. All right? All right, guys. It's a quick 13-minute snippet on PCOS and the 2 questions. Hope you guys enjoyed it. Like I said, I don't know if anyone's going to be in D.C. next weekend. I will be teaching the second half of the physiology section at the D.C. Kaplan Center next weekend. If you are there, come by, say what's up. I'd love to meet you. Always want to thank you guys for the support. Many of you I know are purchasing or downloading my non-medical book, The Chronicles of Atlantis. I really appreciate the support. I hope you guys are enjoying the story. Let me know what you think. It is still available on Amazon and Barnes & Noble for download or for hard copy, or ebook or hard copy. I hope you guys enjoy it. Let me know what you think. Wish you guys all the best, and I'll be seeing you soon.